Hello, everyone, and a very warm welcome to today's webinar, Telemedicine and AI, Technology in Delivering Preoperative Care. So my name is Nicholas, and I'll be your moderator for this insightful session. And thank you for joining us on this Saturday morning. So first of all, welcome all of you from across the globe. And actually, currently in Hong Kong now. So whether you are a surgeon, anesthesiologist, nurse, administrator, or simply passionate about healthcare innovation, today this is the right place for all of us. So as we all know, the preoperative phase is a critical window for patient optimization, risk reduction, building trust. But yet traditional in-person models face challenges with access, efficiency, and data integration. So today we are going to explore two transformative technologies, telemedicine and artificial intelligence, which are converging to reshape this landscape. So, telemedicine is the remote delivery of clinical services and patient monitoring using telecommunication technology. In the preoperative care, it creates a structured digital workflow, a virtual pipeline that replaces or supplements in-person visits. So, this allows for remote patient assessment, education, and also follow-up. Artificial intelligence refers to the computer algorithms that learn patterns from large datasets to perform cognitive tasks such as prediction, classification, and decision support. So its role is not to make decisions, but to augment clinical judgment with data-driven insights. So today we are privileged to have two exceptional leaders in this field with us. First, we have Dr. Beh Hooi Chin, family medicine specialist from Department of Primary Care Medicine, University Malaya Medical Center. She will ground us in the practical realities with her talk, Telemedicine in Practice, Preoperative Setup and Workflow. She will share the how-to from technology selection to patient engagement. Our second speaker is Associate Professor Dr. Hairil Rizal Abdullah, Senior Consultant, Anesthesiologist and Perioperative Physician at Singapore General Hospital. His presentation, Augment, Not Replace, AI and Telemedicine in Preoperative Optimization, will dive into the future-forward synergy of AI, enhancing decision-making and personalizing care. So we'll have both presentations by the experts, followed by a live Q&A session where you can submit your questions via the Q&A panel. So you can either send it in the chat box or from the YouTube. And this webinar will be recorded and available online. So without further ado, let me introduce our first speaker, Dr. Beh Hooi Chin. Dr. Beh is not just a clinician, but a pioneer in leader in telemedicine implementation. Since 2020, she has been the key person in charge of telemedicine service at her clinic, actively transforming how primary care is delivered. Her expertise is both broad and deep, spanning hypertension, geriatric medicine, and digital health, areas that are critical to managing the complex needs of the preoperative patient population. So beyond her clinical role, Dr. Beh is a dedicated educator and trainer, having provided essential education and training for healthcare providers conducting teleconsultations. She also spearheads quality improvement projects to enhance and innovate her clinic's telemedicine services, ensuring high standards of remote care. Her research focuses on practical large-scale health screening and management, giving her a very strong evidence-based approach to patient care. In short, Dr. Beh brings to us frontline experience, leadership in telemedicine workflow, and a passion for practical improvement. She's perfectly positioned to guide us through the how-to of setting up and running an effective preoperative telemedicine practice. So please join me in welcoming Dr. Beh Hooi Chin. Dr. Beh?
Yeah, hi, good morning. Can you hear me?
Hi, yes.
Yeah, great. Okay, I'm sharing my slide. Okay, can you see in the presentation mode now?
Yes, yes.
Yeah, all right, great. So thanks, Nicholas, for a very kind introduction. I think it's very difficult for everyone to wake up early in the morning, especially on the weekends. But yeah, well done, everyone. You are able to do it. And I think today I'm going to share about the telemedicine preoperative in practice setup and workflow. And of course, I think like I say, it's difficult on a Saturday morning, you might still on your bed and all that. It might be appear that like it's you don't even have to put your pants on, something like that. But of course, I think for today's session, we are going to talk about mainly how does the telemedicine preoperative in practice and the setup and workflow. Okay, this is an outline of my topics. All right. So just a quick look at the background of teleconsultation. So I think we always start with the definitions where you can see from here is telehealth, telemedicine, and teleconsultation. So sometimes even my MO, they might be confused with what are the differences between these terms. So telehealth is mainly like electronic and telecommunication technologies used to provide healthcare and services at a distance. While telemedicine is actually use of the telehealth technology to share and maintain patient health information, to provide clinical care and health education to patients, and also like what we are doing now, like the teleconferencing that we are doing now is actually considered as part of the telemedicine, where like Nicholas is in Hong Kong, I'm in Malaysia, I think Prof Hairil is in Singapore. So I think this is the power of telemedicine that connects all of us together at a distance, and is very convenient for all of us. And teleconsultation is another application of telemedicine that use real time. It's a synchronous, meaning that it's at real time now with the AV communication technology. So sometimes all these terms it's just for you can use interchangeably as long as you know that what would be important of using teleconsultation and the important how do we use this for our patients' care. So of course, there are a lot of many types of telemedicine. So live video conferencing, like what we are doing now, or like we are doing with our teleconsultation with our patients, can be considered as an asynchronous, meaning that you record something first, and then you forward later, you share it to your other consultants and whatnot, or even with the patients, or even like WhatsApp or email is actually considered part of telemedicine. So another one would be the remote patient monitoring. I'll explain it in the detail. And another one is I'm not sure you see, yeah, it will be mobile health. So you'll be using the application. I think nowadays it's very common that they're using health apps for that. Yeah, so this is me, myself, posting for the pictures purposes for our flyers for our hospital. So it's actually part of the live video conferences where you can see the patient straight away synchronous at the same time at this moment. So you can provide consultation and all that to your patients. And then we mentioned like the remote patient monitoring. The commonest that we are using is CGM, the capillary blood glucose monitoring. So where patient can key in their blood pressure or even blood sugars and all that in the apps and all that. So which can actually guide the doctors for monitoring. And we also mentioned about the store and forward just now, like asynchronous telehealth, where patient can actually also measure their blood pressure and all that, store it in the platform. And then after that is asynchronous, meaning that after that, the doctors can actually review the results. So we do have some studies actually doing this. We can share it with you later if you're interested. And again, application. So like what we have in our hospital, I'm from hospital, we do have application where patient can actually just dial in to actually see the doctors through the teleconsultation. So what's the aim? I think importantly is to use it to communicate. It's a technology to provide support healthcare when distance separates the participant, especially I think during COVID time where everyone couldn't travel to anywhere. So teleconsultation and telemedicine is actually very important during that period. And of course, it's also part of the important for education, research, administration, and even for public health kind of awareness, create awareness or campaign, all that also can be done through the telemedicine as well. So Time Magazine one time have called it as healing by wire. So it's a internet wiring. So when I Google it, it's actually showing me this kind of picture when I'm trying to search for some pictures. So it's actually healed at distance. So what are the benefits? Maybe I can show you a very simple video that actually we won a competition by showing what are the benefits and also evidence-based of teleconsultation. It's just a very short video. I hope you can hear.
Ever wonder about patients?
Can you hear the sound?
Ever wonder about patients' struggles coming to the hospital? Facing the traffic jams, searching for parking, long waiting time, and so on. It is very frustrating. good that now we have teleconsultation services in the UMMC. Teleconsultation was shown to improve access to care by eliminating geographical barriers, allowing patients to access healthcare services irrespective of their location. Forget all the hassles coming to the hospital and avoid the risk of falling in the hospital. Apart from that, it saves time too. Patients can log into the system wherever they are, just before the appointment time instead of coming to the hospital very early and wait for the doctor. A systematic review reported that teleconsultation facilitates timely access to specialists, reduces waiting times for expert opinions, and potentially improves patient outcomes. Teleconsultation is reported to be cost-efficient too. For some chronic diseases, teleconsultation enables consistent monitoring, which leads to improved treatment adherence and reduced hospitalization readmission rates. Clinical outcomes aside, you might be wondering what patients feel about using teleconsultation. Various studies have reported high satisfaction among patients who use teleconsultation for their care. Their family members can also join in the teleconsultation at their convenience. Many studies reported that teleconsultation is as effective as face-to-face in-person visits. Teleconsultation can also minimizes the risk of infection by avoiding the hospital, which is full with bacteria and viruses. These being said, not all patients are eligible for teleconsultation. For now, only patients...
Yeah, so this is mainly the benefits of teleconsultation. So if you see from some of the evidence we have shown on the video, like of course, it's improved access, and also importantly, reduce because like in Klang Valley especially, it's like traffic jam and all that. So by the time that my patient reach my clinic, usually their blood pressure will be very high because they are rushing, stuck in the traffic jam and all that. And then it also save cost, save the traveling time and all that. So this one is generally as a teleconsultation in a general way. So later I'll talk about how about for preoperatively wise. So I actually found that one systematic review mentioned that the use of telemedicine are beneficial in preoperative assessment and diagnosis. And of course, this systematic review, they also covers for evaluation after surgery, like the outcome of the surgery, as well as the follow-up visits. And also, but that is mainly for the clinical aspect wise. So for the benefits for patients, like they mentioned, avoiding unnecessary trips to the hospitals, they save their time, and then they reduce their no need to take leaves just to attend to the hospital. So we do have some other studies shows that that I'm doing now for qualitative study that I do interview a teacher. So she's a patient of our in our primary care clinic. So she actually mentioned that she no need to take leave because you know how difficult for teachers to take leave in Malaysia. So usually so that's why she really like it in the way that she no need to take her own annual leave to discuss with her ministers and all that. So she can just take the time off for about less than half an hour. Then she can attend the teleconsultation with us for her chronic diseases. That's why she really loved it very much. So since we are in the topic of telemedicine and AI, so I'm trying to use the notebook LM. I really like it very much to actually have this infographic picture and summarize for this systematic review. So if you can see from here, it's actually part of the one of the finding that mentioned for preoperatively diagnosis, they actually improved accuracy. And then for post-op wise, also they have a better mix as well and reduce unnecessary visits. And then for enhancing for follow-up and remote monitoring for patients as well. Well, of course, it's always come with benefits and barriers. So for barriers wise, I think the main thing will be the implementation part. I think we have discussed that with Nazra yesterday as well, that it's very difficult to recruit patients sometimes. So there's some challenges faced by the healthcare providers as well as patients themselves. So we do have a lot of studies. I'm now doing implementation study, how to improve the recruitment rate and all that to improve the teleconsultation services. If you like, you can email me also if you're keen to know more. So other than the systematic review, I do find a few more like evidence and articles, although there's not many evidences out there still, there's still some research gap. So I found that there's one paper stated that it's a RCT that they actually recruit some of the patients, including pediatric patients, And then they stated that they actually is from a rural area. So the nurses actually pass the list of the patients with the criteria and all that to the surgeon, and then they have a look on the list of the patient. And then they decide whether this patient are suitable for teleconsultation or not. And then they actually remove excluded about 33 of the patient, about 65% of the patient not suitable for surgery. And then the rest of the patient are actually all of them 100% successful, underwent for surgery, and then discharged very well, and outcome also very good. So in a way that if let's say we do have this kind of pre-screening or pre-operative assessment, it will actually improve the patient's outcome, and also of course reduce the what we call the cost and all that. Because otherwise the patient comes to the clinic, then they might think, oh, you are not suitable for what we call the surgery, then it will actually causing more cost to the patient. So the other article also similarly, but this is for mainly for gynae patient. They go for hysteroscopic surgery. So from here, it stated that patient actually demonstrated more significantly in the traveling time spent in the hospital also reduced, and then the travel expenses. If you know that like hospital, the parking, and then the food and all that. So they also include the meal and all that as well, but I did not put it in the slide. So there are a lot more expenses, the cost effectiveness wise that they actually shown in this paper. And this paper also good that they actually mentioned that they do have provide education by the NS doctor preoperatively to actually educate patient what's about the hysteroscopic, I mean, what's the procedure like and all that. So patient actually understand more. And also all of the patient in the telemedicine group also most of them, I mean, all of them are actually satisfied with the educational and also the telemedicine processes and all that. So generally it's still in a good way, pointing to a good way for telemedicine. So when we talk about all these evidences for preoperatively assessment, so what is the principle of conducting teleconsultation? So of course there are some do's and don'ts. It's not like you recruit every patient under your clinic to go for this teleconsultation. So there are some principles that we need to follow as well. And I think in Malaysia we're following a few guidelines where you can see here. Some of the one that mainly we are following is the last one, that the MMA virtual consultation. It just recently have renewed 2025, but it was actually not enforced by law, so we actually take it as a guide, as a like a guidance lah. All right, and of course, if you were to practice to conduct teleconsultation, we follow the usual MMC code of professional conduct. It's a similar like you are seeing your patient physical. So these two acts are the main act that we follow for teleconsultation purposes. So I'll just quickly run through this because the act is actually many pages. I'll just down into summarize it. Okay, so what we have actually found in the act is actually they mentioned that the virtual consultation can be only carried out for a patient or a person who is already registered as in the clinic as a form of continuation of care. So we do not see patient as an acute kind of like let's say you do have fever and whatnot. We don't see this kind of patient. Even for preoperative assessment, of course, we don't see those patients who are acute or having acute symptoms. So it still need to be seen by face to face. So it means that you already are a registered patient in the clinic. So for my setting, because we are only seeing mainly chronic patients, so the patient have to be seen in my clinic for 2 years, then only we can recruit them. But I think for the clinic in the preoperative in PPUM, need to be seen at least once physically, and then the subsequent you can follow up by tracing the blood results or echo results and your lung function tests and whatnot. So those kind of things that you need to actually plan it with your team. I'll further explain later. Plan it with your team and then to decide what are the inclusion criteria for your suitable for your setting. Okay, and of course, I think similarly with your usual face-to-face, you must have some, must have the competency as well, and of course, competency through telemedicine, and also you have to have a valid informed consent with patients. In this act, it's actually stated you must have the written informed consent. So you might think that, oh yeah, it's already telemedicine. Why I need to come to the hospital just to sign up the written informed consent, and then only I can go for teleconsultation. But I think in a way, like we mentioned, you need to be a registered patient to begin with. So the next subsequent follow-up, then you can go for teleconsultation. Okay. And I think the rest are quite straightforward. And the recent, I think, not sure whether you are familiar with one of the guide actually stated that you cannot provide MC, the sixth certificate, by doctor through teleconsultation. So this is one of the, when during my qualitative study, my patients also do mention that they find it difficult if they go for teleconsultation, they cannot take MC. But by right, strictly to say that sixth certificate is for those patients with acute presentation, where you cannot go for work and all that. Not because you come for chronic follow-up, then you should get your MC. So that's why this is something that I think is quite logic and common sense lah. Yeah, all right. Okay, because some safety measures, I will mention it in detail later. Because when you are like, we mentioned that you need to take consent from the patient, and then from there, you need to explain to the patient that if let's say you do have some acute problem, we might need to see you again in face to face. You cannot be forever seeing teleconsultation for like many, many years and then just renew your medication, which is not right. So in the, it's also mentioned we need to see the patient at least once physical, and then subsequently you can see many, many times in teleconsultation is still fine. Until if you do have acute problem, then you have to see face to face again. All right, so this is something important to consider when you are trying to set up in your clinic. You have to mention to the patient, you might need to have some like the participant, the patient information sheet and the written consent form and some inclusion criteria and all that for patient to look as well. Okay, you have to explain to the patient before we recruit them. So of course, it's similarly with the, like we mentioned earlier, if let's say patient do have cognitive disorders or they do have language barriers, they have visual or auditory problems, impairment, I think those are, you cannot recruit them for teleconsultation. Okay, and of course, acute symptoms as well. Okay, so I think again, you might think that privacy and confidentiality. So another qualitative study that we interview our doctors, actually they worried. They worried that the patient or their caregiver sitting at the side recording the session. So again, this is also part of the things that you need to put in your participant information, the patient information sheet. You have to mention that you are not allowed to record. So similarly to our physical, patient cannot record us, right, in the physical consultation. So it's a similar thing. And of course, if they do record it, we sometimes we might not, we can't help it because we can't see. Maybe they're just at the back of the laptop or whatnot, we can't see. But again, we will just we will explain to them during the recruitment that they're not allowed to record. And of course, we need to inform to the patient that their attire, their places cannot be too noisy, that kind of places. Sometimes they do it in cafe, which is very noisy. I do have a patient, he did not put on his baju. He did not put on his clothes when during the teleconsultation. He just like naked, half naked. So it's something, it's a man, like it's a man, but it's still a bit of discomfort, like, right, to the healthcare provider. So those are things that you might need to explain to the patient as well. Okay. Again, if we were to look at, I was told that this session also we do have some participants from overseas. So maybe it's good to have a look on the telemedicine regulation in Asia countries. So it's a very heavy guidelines. I mean, yeah, it's a review. Like it's actually very good. They summarize all the medical act and the whatever regulatory kind of documents from each country in Asia. There are 51 countries. If you're interested, you can actually read more. But so those are the evaluation they look at. The one that I summarized here is like so many, about 13 of the things that they are looking at. I won't delve into detail lah. So since we are neighboring country Singapore, I just comparing these two. Okay, I have to declare that this is from ChatGPT. Okay, I have to summarize it in a very nice table. So maybe I won't read through all, just to mention about the binding law. So like I think for Singapore, they do have their own act for telemedicine providers as well. But for our, like I mentioned earlier, for our Malaysia, we do have the act, but it was not enforced by the law. It's just a guidance like that. Okay. So, and for this slide, maybe I will look at mainly like what are the suitability for assessment and all that. So, I mean, if you were to go for conduct a teleconsultation, you must go through some training. So it can be your in-house, let's say you're in any other hospitals, government hospitals, or clinics, or even your GP clinics, those doctors who are going to conduct a telemedicine need to have training first, okay? And of course, sorry, I mentioned about GP. Too used to, I'm a family medicine specialist. I mean, for anesthesiologists, then you need to go through a training in your hospital. So I think those are the things that you need to have a team with your IT team and with your team who are good in this kind of technology and the telemedicine aspect. So you have to sit down together to form what kind of module and all that. But nowadays, there are a lot of modules out there. And for PPM, we are also copywriting our teaching module. So hopefully it's ready by mid of the year. Then we can actually also launch it as well. Then you can actually learn it. Okay. And I think, yeah, like I mentioned again, course of practice, we are following the usual kind of physical professional conduct lah. Okay. All right. So the third, so we have mentioned about the act and the important about it. So now the requirements of teleconsultation. It can be for the hardware itself and as well as the software, the platform, which one that you are going to use. Okay, so this is what, ignoring my messy clinic, okay, but it will be similar if let's say you do your anesthesia, I mean your anesthesia clinic, so you can have this setup. Mainly the hardware will be like cameras, important stuff will be like for our setting. Previously we used Google Meet. After that, after they have purchased some they do have some what we call the discussion and all that, then we decided to go through Zoom. So because we do have this waiting area that we can put our patient in the waiting area, install that kind of thing. So importantly, also we have first speakers, and then your internet is important, as well as the provider and another laptop. So actually, if you look at it, the cost to prepare all this instrument might not be very expensive. Actually, it is still, I think it's affordable. Of course, if let's say you have some emergency, what we call like the patient couldn't connect it through the Zoom and whatnot, then you can actually call the patient. But by telephone consultation, is actually not part of the act. It is not in the act. So in the act, it's actually video, the visual consultation. I think similarly it's like MO. So we do have some, similar setting. And after that, we do have this application. So you can also set this with your own institution that you wanted to have some application to actually for patient to log in. So we look at here, this is our app in our hospital. The what we call the appointment is already set up before. When you already recruit the patient, and then the clerk will actually put it in the setting, in the EMR, electronic medical record, and then the patient can see the appointment in the apps straight away. And then on the day of the teleconsultation appointment day, they just need to click on this link, which is actually safe. You cannot share this link to others. And then others also cannot reach your link because it's in your apps, in your phone. Okay, so it's actually very safe and secure. So, but of course, there are so many hospitals, they do have their own apps. IGN have their apps, and then the other KPG also have their own apps. So we do have some discussion with our digital health unit from MOH last month. So they actually wanted to collage and also combine all these apps so that everyone can actually share data sharing, that kind of thing lah. So that is also something good initiative from our MOH. Okay, I think the hardware and the software quite simple. You just need to discuss with your IT team. Not very difficult. But the most important part is actually the patient eligibility. So of course, I'm a family physician, and I did not really go to NS clinic for attachment during my training. So I actually looked through some evidences online. They did not really specify what are like pinpoint what is the patient suitability for teleconsultation. So again, I think this is primary care, but it will be similar with the NS for pre-op assessment. So let's say chronic diseases, you wanted to control patients' blood pressure and blood sugar before operation, right? So that will be the similar thing that you want to make sure that they can able to like adhere to medication. And then it will be good if the patient have home self monitoring for sugar as well as home blood pressure. So if those are the patient that you wanted to monitor for your preoperative clinic, then it's important for this in your recruitment, meaning that the patient can be only recruit for let's say for the to assess their chronic condition, for their control of their blood sugar and blood pressure, if they have home blood pressure monitoring or blood sugar monitoring. So you can always decide what do you really need for your clinic. And then of course for children, you need to get the consent from parents and all that. And then for I will look about the clinical patient as well in a short while. And I think similarly to for elderly patient as well. But here they actually mention improve care for patient with dementia. But again, it depends on your setting. If the patient is demented with no caregiver, I don't think the patient is suitable to be recruited for teleconsultation, because I don't think the patient able to do it alone by himself. Yeah. So when I look at the roles of the NS in preoperative clinic, it's actually to identify and ensure patients' underlying medical conditions are optimized, perform care coordination, patient education, including patient education and counseling to maximize the patient's safety and optimal outcome during the operation. So I look at another systematic review is actually focusing more on gynecological practice, but this is actually as a telemedicine as a whole. They do include two studies related to preoperatively, where this paper actually mentioned they actually recruit patients with 18 to 65 years old to go for hysterectomy. So let's say if you found that you have to delve into this RCT, uh, whether this group of patients, if let's say you do have patient aged between 18 to 65, you want to recruit them for hysterectomy with low risk for benign condition, not for malignancy, then you can consider to recruit the patient based on this literature. So I think when we wanted to finalize our patient eligibility, we have to go through all this literature review to decide whether is it safe to recruit this group of patient. Because we cannot simply decide, oh, I want to recruit this patient, I want to recruit patient with malignancy or whatnot. So we really have to go through the literature to find out what group of patient is suitable to be assessed preoperatively. And actually, when I read through these two papers, they're actually same papers, just that they report a different thing. One is report the patient's post-op outcome. In another paper, they actually report patient satisfaction and the duration of return to work, post-op, all that are reduced. So generally, the outcome is good based on these two papers. But again, if you still have to discuss with your team, I would say all this literature review to decide on your patient eligibility is very important. You have to go through that in a very detailed way. Okay, so the other thing, the other group of patient will be pediatric. So I understood that, of course, I think unless you do need some patient, pediatric patients go for operation. So they only recruit patients who require routine preoperative laboratory studies. So like they do need some blood tests or some other echo finding and all that. So they recruit those patients to review the blood tests and review the findings. So, and also the parents also reported that they think that the visit from telemedicine for preoperative assessment is very effective. Yeah. Okay. All right. So another one will be the elective Caesar for those high-risk patients with antenatal patients. So this is important to look at. I'm very surprised also they actually recruit those with high-risk patients, antenatal high risk. So like if you can see the lists are very long, they actually do recruit all these, suggest to recruit all these patients for telemedicine. So their justification in their discussion are mainly they think that the main purpose is mainly to gather the necessary information, communicate a plan, set the expectation, and also determine further workup. What are the workup that necessarily, and then they will refer accordingly and order the investigation accordingly. The telemedicine for this group of patient, for the high-risk antenatal patient, they did not look at like, if let's say they do have scoliosis or they do have some difficult airway, which they think that from this paper, they think that is you can't change that anyway. So meaning you just need to assess it and to provide some set expectation and all that and educate the patient rather than, because like the scoliosis all that they might not able to change that when the patient is pregnant. So that kind of thing. That's why I think it's quite justifiable for them to recruit this group of patient. And also there are some studies shows that they can actually even examine the airway during teleconsultation. There are some studies actually supports that as well. And then, I think ultimately the patient, when they're admitted to the ward, they will still need to be assessed again physically, and also what we call assess the formal airway assessment again, preoperatively. Yeah. Okay. So we talk about all these eligibility and everything. And now if we were to conduct the teleconsultation itself. So during the teleconsultation session itself, what will happen if there's something happen? So that some risk management is important as well to include it in your participant information sheet and included in the training as well. So when you train the doctors, you must tell them what are you going to do if the patient is distressed, or if the patient suddenly have something and all that. So what are you going to do? So this is what I found it from one of the line from American Society of Healthcare Risk Management. So they actually, one of it from the beginning, even from the beginning itself, whether the doctors are credentialed to begin with to conduct the telemedicine. So the training, like I mentioned earlier on, training and all that, and of course the informed consent and all that, and then whether what are the patient eligibility and the population of patient that important for you to recruit. And then I think reimbursement so far in our country, we do not have this insurance coverage, and also reimbursement for teleconsultation. And again, education training and all that, and then the acts all that have to be revised. I mean, have to follow as well, and the technology part, and also the hazard training, and the procedure to use for disaster or disaster planning. So this one I won't delve into detail because we did not discuss about that even in our setting as well. So like let's say just now we mentioned what are the contingencies plans that you can do. Let's say a patient is in distress. If let's say the teleconsultation get difficult, so I don't receive some call from my FO, patient are very nagging, asking a lot of questions, got a lot of active complaints, which will need physical examination, then you might need to convert that the teleconsultation to the physical consultation. And of course, if you do have poor internet connectivity, you do have some failure in EMR, then you cannot connect to the patient, then you cannot proceed with telemedicine. So those are the things that might happen. Then you might need to convert to physical consultation. Okay. So I think lastly, um, communication also important. It might be slightly different from your face-to-face kind of consultation. So whether the patient do understand you, or sometimes you might wasted some time like, hello, hello, can you hear me? Hello, hello, like that. So those are things that we might need to consider during the telemedicine as well. And of course, patient might appear frozen and all that. So those are a lot of things that you might because if the patient appears to be frozen, then you cannot be keep on talking to the patient. You might need to pause and then assess first, and then communicate properly later on. You might need to repeat again, something like that. Okay. So I think I just a very funny video that show that how important is the communication for patients. Okay. So I just show you.
Are you the Bluth?
Dr. Wordsmith, how's my son?
He's going to be all right.
Oh,
Thank God.
finally, some good news
There's
from
no
this
other way
guy.
to take that.
That's a great attitude. I gotta tell you, if I was getting this news, I don't know that I'd take it this well.
But you said he was all right.
Yes, he's lost his left hand, so he's going to be all right.
You son of a bitch! I hate this doctor!
He's a very
Actually, it's important to mention that communication is very important. In it can be in the physical or in the teleconsultation. So if you did not mention clearly, then patient or the caregiver might have some miscommunication, then might have causing some dissatisfaction. Okay, so this one I'll just skip because I look at the time is ticking. Okay, of course we do have some communicative challenges like lack of visual cues. You couldn't really see the patient well sometimes, or time constraint is also important thing. And this is also important thing for you to decide when you are going to set up. So whether how much time frame are you going to give per session for patients. So let's say it's in the Zoom, but although it's like our setting is in the Zoom, patient can wait in the waiting room. But if let's say you already finish it early, then you can actually discharge a patient from Zoom, and then you can call another patient. Previously, we are having a very rigid system where we only set 30 minutes for each patient, quite a long actually, 30 minutes for each patient, plus included the documentation as well. So If the patient finish early, then we have to wait. The doctor and the both patient have to wait until like let's say 9:30 or 10:30 the appointment. Then you have to wait until 10:30 only you can start the next patient, which I think a bit of time consuming. That's why we change in a way we can place the patient in the waiting room. So these are also an important thing that you can consider when you are going to set up your setting. Okay. So I think it just yeah, how to overcome it. I think you just might need to repeat back or might need to teach back again, ask the patient to repeat what do they understand and all that, and frequent confirmation. And let's say I mentioned patient is frozen, you might need to make sure that is it patient can still hear you before you proceed to the next agenda in the consultation. Okay. All right. So of course, I think time constraint, yeah, I will talk about some of the communication part for time constraint, rather than you ask, how are you today? Why are you in the clinic today? Like that kind of very open-ended kind of communication might be a bit difficult to be implemented in teleconsultation. Sometimes we might need to be straightforward. Okay. All right. So I think technical issue, I think this one not a I think is common sense. I think everyone is good in that. Okay. So I'll just show you that for one of the example of might not as good kind of teleconsultation that we did it during pandemic time. Okay, so of course I would not cover all these communication skills for teleconsultation. I'll just cover one or two important things, especially tailor for the perioperative preoperative assessment. Okay, so this is one of the technical issues.
Told about this teleconsultation by your
I
previous
can't
doctor
see
when
your
you came.
face, doctor. Sorry, I can't see your eyes. I only
Really?
look at your neck only now.
Oi? Can you
You
see
have
me
to
now?
lower a bit. Sorry. Yeah, now I can see you. Yes. Thank you, doctor.
Just hold on, Okay, I need to.
Okay. So I'm not sure why are we wearing masks because we are doing telemedicine. Why are we still wearing masks? Okay, because during pandemic time. So you see, you might wasted some of the time and you might not want to expose your inappropriate area to the patient, right? So before you even start your teleconsultation, you should actually put it in the night. I mean, prepare yourself, like your head, your eyes, and all that, rather than you showing the patients your chest or your other area of your body. So those are important thing as well. And of course, if let's say different gender or different in different gender, you might feel a bit discomfort if let's say you are showing inappropriate area. But of course, so that's why you need to be ready for that as well. Okay, so I think this one is just yeah, appropriate distance, not too near or not too far as well. Okay, so this introduction for patient. It so this doctor, she actually took quite some time to just ensure the patient identity. Just to ask her name itself, she also took quite some time. So those are things you would like to avoid during teleconsultation.
Hello, yes.
Hello. Is that hello? Is that I think the name is Zainab, right?
Yes, I'm Zainab.
Boleh saya cakap dengan Puan Zainab?
Saya Puan Zainab. Ya, tengah speaking.
Oh, okay, Puan Zainab, saya Dr. Lee from panggilan daripada PPUM Duka.
Yes, Dr. Lee.
Hari ini saya nak buat telefon Puan untuk buat some consultation lah.
Boleh.
Okay. Puan.
Okay, I won't proceed further. So you can see that she like taking some time to just ask him why, and then you have to make sure the patient name, then you just ask straight away, that kind of situation. And also you can see a bit of lagging in the internet. So those are things that we might need to consider when you are setting up the clinic. But I think in the hospital, the LAN cable usually should be okay and quite stable, like internet connection. Okay. So just very straightforward. I'm Dr. Beh. I'm calling from PPUM. Today we are going to conduct a teleconsultation for your preoperative assessment. May I know am I speaking to Dr. Nicholas and something? Yeah. So if you were to to confirm your IC or RN or something like that also can. Okay. I think I will skip this.
Okay, your recent HbA1c, it shows.
Just may need to show because the doctor mentioned to the patient that, oh, you got diabetes. your sugar very high. So that kind of consultation, the communication skill that might shock the patient. And then the patient was very worried and very scared. So again, I think in preoperatively, maybe when you would like to mention some of the bad news about the echo findings or whatnot, sometimes I need to deliver it in a um, how to say, deliver it in a proper way rather than, oh, your heart is failing, or so it must be something that in a very gentle way to inform the patient on certain results. Or sometimes if you think that these results, let's say the patient suddenly noted to have HIV or whatnot in the blood test, then you should not reveal that some sensitive blood results over the telemedicine, because you might not know who is actually beside the patient. Maybe his partner, her partner is beside. So you might not able to reveal those sensitive blood results through telemedicine as well. So you might need to call the patient and come back as a physical consultation. Okay. So I think lastly, I just have discussed this with Nadra as well, that we do face some challenges when you are trying to implement your teleconsultation in our institution as well. But do not give up. Okay, I think this is a way that we need to move forward for our for the healthcare services. So you might face some barriers or challenges from your higher up or management, or even your doctors, even your patients, but do not give up. There's it's a stage of change. I think I'm sure everyone's familiar with stage of change, but this is very interesting. Actually, it's a stage of change for transformation change in telemedicine. Is very interesting. So whether you see there's actually 9 steps until the patients or the manager or even the doctors to actually accept the telemedicine services. For our clinic also, we actually took some time. Okay, so I think Nicholas has introduced this as a quality improvement project that I'm doing. So we do find some of the challenges from patients. Here, the fishbone is a Chihuahua chat lah. We do find some challenges from patients, system and healthcare providers barriers. Then we try to improve it, and then we do have then we found some other steps lah or drivers to actually improve our take in our clinic and improve the quality of the teleconsultation in our clinic as well. So I would say everything will have their pros and cons, and of course their barriers, especially when you want to introduce some new services in your institution. So it's always, if you go through all this proper method and all that, I'm sure that your team will be able to implement it successfully in your institution. So here, of course, our results might not as good compared to those in Singapore. I do have my friends that actually um, have a patient recruitment for about 1,000 plus per month. But for our setting, we are like very little to begin with. But last year, we do have about almost 1,000 lah. So at least we can have it at that number as well in the end. Yeah. So I think some take-home message. And of course, I think there are proven evidence shows that proven benefits of telemedicine, but still there are some research gap lah, I would say. When I do the slide, I was like really finding a lot of gap. Then because if you want to do some research, then we can collaborate together. Okay. And of course, some ethical consideration when conducting telemedicine, then the workflow, setup, patient selection. So all this must come into very clear and very important consideration. And of course, depends on your country's act or law, or even your institution setting, and the guidance from your institution is important. We do have our legal lawyer to in our team when we form this telemedicine actually. Yeah. So, and of course, some important point for the contingency plan, and also identify some implementation strategies to improve it as well. So I think with that, thank you very much. Yeah.
Thank you. Thank you, Dr. Beh, for the very incredible, clear, and practical roadmap. So you have actually demystified the setup process and highlighted the very real benefits of the workflow efficiency and patient satisfaction coming from a PPUM point of view. I think we have quite a few, I personally have a few questions to ask you regarding setting up this clinic, but we'll delve on it later. So it's my pleasure to introduce our second speaker, Dr. Associate Professor, Dr. Hairil Rizal Abdullah. Hi. Hi, Dr. Hairil. Okay, so a brief introduction. Dr. Hairil Rizal Abdullah is a senior consultant anesthesiologist and perioperative physician at Singapore General Hospital. And he's a leader whose career perfectly embodies the convergence of clinical excellence, systemic innovation, and technological transformation that we are here to discuss. So his foundational work began a decade ago when he pioneered and led the establishment of Preoperative Assessment Center at Singapore General Hospital. So transforming it into a one-stop multidisciplinary hub. So this was not just a clinical project, it was a complete re-engineering of the preoperative workflow. So a testament to his focus on patient optimization and system efficiency. Dr. Hairil's research portfolio is vast, with over 70 publications, and crucially, his work bridges direct clinical impact with cutting-edge technology. So throughout his prolific career, he has won multiple awards, including the Distinguished Champion of Change Leader Award in 2022, and also the prestigious Lee Kuan Yew Scholarship by the Public Service Commission. So in short, he has not just studied or talked about the future of preoperative care. He builds it from redesigning clinical pathways, championing enhanced recovery after surgery, to implementing AI tools and leading value-based care transformation. He operates at the very intersection where today's telemedicine practices meet tomorrow's AI augmentation. So please join me in giving a very warm welcome to Dr. Hairil Rizal Abdullah. Dr. Hairil?
Thanks, Nicholas. Very kind introduction. And I must say, I thoroughly enjoyed Dr. Beh's talk just now, and thank you for that as well. Let me try and share my presentation. Let me know if you are seeing the correct
Yes.
mode.
Yes.
Yes?
Yes, maybe you can put on the presentation mode. Yeah, it's good. It's perfect.
Okay. Yeah. All right. Great. So again, yeah, thanks, Nicholas. Appreciate the invite from the society as well. So I'm going to shift the gear a little bit, and I think it's a very good, Dr. Beh's talk gave a, Dr. Beh gave a very good segue to my talk, which is the pre-op assessment in the AI era, right? So if you're going to do pre-op assessment via teleconsults, if you're going to do pre-op assessment, and divest some of the pre-op assessment to other practitioners, for example, in family physicians, which we do over here as well, or our advanced practice nurses, our periop nurse, and whatnot. AI is the very important tool that we can use to ensure we are being careful and of course fair to the patients. And I would really like to see more adoption of AI methods and AI tools in periop medicine. Anyways, so thanks, Nicholas, for the introduction. I'm Hairil. So nowadays, I spend most of my time driving value-based healthcare reform in the cluster, Sing Health, which is a cluster of 13, 14 different health institutions, hospitals, and a string of polyclinics. We take care about 1.6, 1.7 million patients in Singapore, as well as in Singapore General, which is the flagship hospital of Sing Health and Singapore. At the same time, I'm also the director for Data Science and AI Lab here in SGH, and that explains why I'm quite interested in converging AI technologies, health systems, as well as periop medicine. So my PhD is actually in data science and AI in use in healthcare. So prior to that, some disclosures. I'm funded by NMRC in Singapore as well. And these are some of the latest disclosures that I have from last year. So why pre-op assessment? I think most of us here on the call understand why we need pre-op assessment, to reduce risk of periop morbidity, mortality, and so on and so forth. So to put in simpler terms, we do risk assessment. We formulate risk mitigation strategies once we find whatever if there's any significant risk, and more importantly, we counsel the risk, right? So it's not just enough to, just know there is a risk. We need to be able to reduce that risk and let the patient know what is the, what is all about. And I think this is just fair to the patient and the healthcare system. So why is it important though? I mean, we know we are quite safe, but frankly, if you look at the data, and this is from 1 decade ago, 2016, I think it's still more or less about the same. 15% of our patients do develop one or more complications, and not necessarily the serious complications, but even mild complications is still considered complication is relevant to the patient. Most importantly, the most frequent, for example, PONV. It is extremely important for the patient, and it will be quite devastating to a patient, especially if you don't even expect it or even know that there's actually a complication, right? A potential risk. So it's very important. The question now is that how can we predict? Because, hey, if you're going to find that particular risk and you're going to mitigate that risk, you need to be able to first identify that risk properly, right? And there are many risk calculator out there. And of course, at the end of the day, it's up to the provider's experience and whatnot. But you can imagine in a complex healthcare system, it is, the most frequently is the MOs and the residents who see the patients in the clinic, or as I mentioned, now more and more non-anesthesiologists, practitioners, our, dear family medicine colleagues are helping out, our advanced practice nurses and whatnot. So how can we be consistent in the risk and in the care that we provide to the patient across all of these different providers as well as different experience? And I think this is, a very important challenge. So since machine learning came about a long time ago, I think the work of machine learning in Periop medicine and anesthesia started at least nearly 2 decades ago. We've done multiple predictive analytic techniques to identify risk based on all the data that we have. As more and more hospitals and healthcare system uses electronic health records, you have a lot of data that you can use to input into the machine learning models and identify risk very accurately, right? So I give you an example. The Americans, one of the biggest database of risk surgical calculator out there, which is ACS NSQIP. The initial data set that they used previously is about 500, 600,000 patients. And this was like a decade ago, right? And the latest iteration of it in 2023, that used up to 2 million data, 2 million unique patients to be able to give, the risk calculator its accuracy, which is very accurate. But then comes the question, how transferable are they? Because, hey, if I were to use ACS NSQIP calculator in my setting, I'm using data set of people in Baltimore, people in New York, people in Boston, which may not necessarily be the same with my patient. We have different health system, different, health epigenetics, different surgeons, everything's different, right? So is it still valid? And I guess you can use it for, to gauge the pattern, but not really the specific numbers, right? So to do that, I think we need local context. And to give a little bit of local context, so in context of this talk, I'm speaking on behalf of Singapore General Hospital. So in SGH, it's quite an old hospital. We have been in the list of the Newsweek Statista top 10 best hospitals in the world since 2019, I think, because we do invest a lot in our R&D, and we see about 35,000 surgeries a year, 35 to 40,000 surgeries a year. And when I say that we invest a lot, we, as you can see, for AI especially, so we do have quite a significant number of projects that are actually being built and adopted internally in a Singapore General Hospital itself. So I think about 20% are either adopted or planned for adoption in a real world setting as of now. And we do try as much as possible to build our AI capabilities and AI projects and AI pipelines, right? So I think 2/3 of our projects, AI projects, are actually built inside out by our own labs, departments, clinicians, and whatnot. So a lot of our clinicians are actually trained, like myself, in AI and in developing new models and deployment of new models. So the journey for us started back before COVID in 2019, where, because of that need in the ACS, I wanted to see whether, hey, can we have a more localized version that is applicable to patients in Singapore, right? So this is one of our very first paper. We published in Annals of Surgery on that in 2019, where we used a data set of about, I think, 200,000 or 150,000 patients of ours, to develop machine learning model to identify risks of mortality, morbidity, as well as the need for ICU admission to help with the right siting of patients post-op. And we actually deployed this in clinical care. If you look at the picture, that's me quite way younger. Think about 8-9 years ago, and we did a decade ago, right? So we did this. We deployed this in real world clinical care. And the results are quite great because with this we are able to right site patients better, and it's more applicable to our local patients. But then there are other challenges, right? Beyond from the patient point of view, just now we are also increasing more and more patients in our clinic. We see about 100 to 120 patients a day. We do have other issues, lack of medical personnel, with less and less in terms of the ratio between our MOs, our consultants, and the protocols. As of now, as of today, I think in my Periop medicine protocols, I have about 430 pages of protocols. We try to protocolize everything, right? Everything from ERAS protocols, your pre-op assessment, your this medication, that medication, your whole thing, everything is protocolized. But over 400 pages of protocols and risk description and whatnot, compliance and adherence to this protocol is becoming an issue, right? And for the patient, with increasing complexity of healthcare, the understanding of our patients to what we're going to do, what at consent, there's expectation that we need to consent every single thing, but do our patients actually understand, right? And we're trying to get especially a very young MO to try and explain complex procedures and issues on consent to our patients who may or may not even understand English fully, is a challenge, right? So these are some of the challenges that we see. So it's because of this, we try to tackle maybe all of those problems one by one. So the first problem just now with regards to manpower, it's very busy, as I mentioned just now, and we do have teleconsult, like what Dr. Beh presented, by our nurses. They do that about 40 patients a day, and all of those is really tough on our MOs. In fact, our juniors really hate it. In fact, I think it's more than our juniors. I don't think any of us actually like to be in the clinic. I sit in my clinics mainly because I believe it doesn't mean that I love sitting in the clinic, just seeing the patients. It's just being honest here. I'm sure all of you will feel the same. So what can we do? What can we do to help, right? And I think a few years ago, 5 years ago, LLM came into the picture, right? LLM came into the picture, promise of enhanced productivity. You just ask anything and the answer comes up there. Can LLM, large language model, actually help in our setting? So how does it even work, right? Before we go into LLM, in a very, very extremely simplistic manner, LLM is basically taking the entirety of anti-text writing, plunking it into deep neural networks, huge deep neural networks, and come up with a pre-trained natural language processing model, which is GPT, right? For example, GPT and Claude and all those models are there. And it is despite this saying that it's artificial intelligence, it's not intelligent at all. what it does is basically it comes up with mathematical probability of predicting what is the next word after your word, right? So it's coming out of the predictability, and with that statistical predictability, come up with a long sentence or a page. That's it, right? So there's no logic other than prediction of the probability of predicting the next word. That's it, behind all those models. And we tried to toy with this idea that, hey, maybe we can use GPTs to see patients' risk, right? How does that work? So back in 2023, I think, 2023, we actually published the first paper on the use of ChatGPT for ASA classification. It was in BJA back then. Without knowing at that point in time, all the methods of fine tuning and of GPT and whatnot, they're still very nascent, right? This was GPT 2.5, GPT-3, the first one that came out, the free model. And we found that, hey, actually it works. When we compared against our MOs, the GPT actually predicted better in terms of ASA scoring compared to a cohort of my MOs. So I was like, oh, wow, that's a very good, potential for this. But ASA is simple. ASA is just following protocol, right? How about a very slightly more non-specific kind of assessment, frailty, for example, clinical frailty score, right? Now, clinical frailty score, as you know, is very subjective. It's basically eyeballing the patient, and we use that. And we ran ChatGPT at that point in time across our notes, discharge notes, EMR notes, and whatnot, and to predict frailty. And we find that actually it is comparable to our geriatricians. Patients who our geriatricians label as frail is the same as our ChatGPT model. We say, wow, now this is getting serious, right? So we definitely can do this for pre-op medicine. Sounds like there's a pretty good basis for this. But of course, there are limitations of LLMs as a clinical decision support system, right? CDSS. As a CDSS, if you want to use LLM, most ChatGPT or whatnot out there, they are generic. They are not trained on institutional protocols. They're talking about international and entirety of internet writing just now. But my SGH protocol is not on internet. I'm not sure about for the Malaysian, as you said, in PPUM or in HKL, if your protocols are even on the internet, right? Ours are not. We keep it in our own intranet. There's also concerns about data privacy, and you were to use this to ask about patient. Of course, data privacy is a big issue. GPT servers are all over the world, right? So it goes beyond the country borders. And in case you don't know, most countries, I think Malaysia and Singapore are included, we don't, by legislation, we don't allow the healthcare data of our citizens out of the border, right? So this is also a problem. And of course, concerns about accuracy and hallucinations. I think this is quite known. Everybody, there's so many examples out there on accuracy and hallucinations. So then we wonder, okay, what can we do about it? Let's take it step by step, right? The first problem, maybe the first thing that we should be doing is to teach these LLM models about SGH, about our own 400 pages guidelines. That's the first thing. Second, we need to find a model, ChatGPT commercial model, tough, right? So at that point in time, luckily that for Singapore government, we've more or less worked with one of the providers, which is Claude, and have this thing called pair chat, which is, I will explain a little bit about what pair chat is in subsequent slides. And then we needed to address, because if you're going to use LLM for clinical decision support, you must make sure it is accurate and there's very low hallucination, because this is patient care I'm talking about, right? You have to be very real about it. So we plan extensive beta testing, feedback mechanism, and reiteration of the model. So our first step, we want to teach these LLMs our institutional guidelines. And we found that we are able to generate a more accurate model than our doctors. So this one, we included not just our MOs, but include MOs, residents, and consultants against the models that we tested. and even have a higher inter-rater reliability. That means that, 5 MOs will give you 5 different answers. But if you ask GPT 5 times, more or less it's about the same. It's consistent. So in that sense, it's better for patients because there's no there are no reliability issues between those two. And we published this 2024, early 2025 in Nature Digital Medicine. So MPJ Digital Med is one of the highest impact for AI journals out there. So we did this is our first model, and we find that, okay, so now if you are able to teach these models our own things, and when we test it, it's more accurate and more consistent, right? As you can see. So how did we use it? So how did we teach, right? So we taught GPT using RAG, right? Retrieval Augmented Generation. This is the simplest form of teaching an LLM model. You can do this by yourself and on Claude or on GPT or whatever model that you choose. You can do it even right now. So we did that. And as mentioned, we tested 10 different types of LLM. So not just GPT 3.5, which was the original one. We did on GPT-4, GPT-4o, Gemini, Claude, and all of those, right? And we found that at that point in time, that GPT-4 was the best. GPT-4 RAG model had the highest accuracy in predicting the fitness for surgery. And this was, as you can see, 10 percentage points better than our human testers, right? So our batch of MOs, residents, and some consultants. So, hey, we found this. So what does it mean? It means that we can actually teach LLM, GPT-4 at that point in time, with all this. For example, this is a clinical scenario, one of it. There are so many clinical scenarios. We just give one clinical scenarios, and this GPT is able to look not just at the international guidelines, the entire of internet, but also contextualize that to SGH local guidelines, right? So it came up with all this. Right. Okay. So should be seen by doctor. So if this is a telemedicine by our nurses, and say, okay, so this is seen to the doctor. Why? Because of this. Right. So what else needs to be done, and so on and so forth. So it gave very good answers, and this can then be incorporated into the EMR. So really, very, very promising. Right. As you can see, this is the accuracy, inter-rater reliability. It is very reliable compared to that cohort of humans. It's the same answer almost every time. But then we know that we need to find an affordable and sustainable solution to do all those things just now, right? As I mentioned, GPT commercial is not really feasible, and it's expensive too. So PairChat came about. That is an open government product which is developed by Singapore's GovTech. And what is special about it? It is hosted on a secure government commercial cloud. Hence, there's no worry about the privacy just now. And for us in SGH, it's more or less free. So, it's a free model. You need to pay. It's hosted by the government. There's no logging and whatnot. And the base model is using Claude on AWS Bedrock server. And because of that, we are able to work on this much better. And we decided that rather than using RAG, we use long context. So long context is another way of teaching. So the models, right? So RAG, we look at what it does is that it reads the document segment by segment. So it will pull specific section of the document and then give the prediction just now. What's the next word? This word is very aware of specific section. It's very good. GPT-4 uses this, right? RAG. Most of the commercial one uses RAG. It's very good to be for fact finding and handling large data sets, because they will break all those sets of information and then give you the prediction. But for clinical guidelines, there's a lot of context, because the first few points will or rather the first, some of your points will refer or have reference to the context of the first page or the second page or something like that, because very rarely clinical guidelines use segment specific without context. Usually you need to read the whole guidelines and then understand it, right? So we taught the LLM that way. So not to break it up, you read the entire document first and you maintain awareness of the entirety of the text, and then you analyze and give your answers. So that's what we told the model, the Claude, right? So this is the one that we use for Peach. So Peach, which is our perioperative AI chatbot, uses that, and we've improved, some of the corpus. We do a lot of iterations. So we teach based on 80 unique real-world clinical scenarios, our own patients, right? With 3 iterations. That means quite a number of iterations. We tested it and we developed it well. And so we incorporated all those 400 over pages of guidelines with prompt engineering as well. So we supplement the long context with prompt engineering. I'm sure all of you in the call have used GPT, you know prompt engineering very well, and we are able to fine tune it even further, right? So what did we get? So for example, we have this, right? Say, for example, my question, hey, do I need to suspend aspirin for this patient because my patient has IHD and going for lab coli, right? And it's able to give all those, right? Patient factors, okay, this is the patient factors, is surgical factors. So based on our guidelines, these are the guidelines. So you can imagine if this is if this chatbot, this model is available to non-consultant anesthetists who's doing that, teleconsult work, for example, like what the Beh is doing, or even in your clinic, your busy clinic, it will help a lot. So my MOs nowadays very rarely have to come to me for advice because they have me as an AI, right? So it's much easier, and they don't really have to handle my bad moods and mood swings and whatnot. They are able to get out of those, and the writing is very accurate. And one of the things that we worry about is hallucination. What if the model come up with something just because it doesn't know about it, right? And this is the concern that people usually have. And I give you an example. Say, hey, my patient is on blister beetles. Blister beetles is, blister beetles, the ban mao, the Chinese medicine, the TCM medicine, right? So sometimes our patients with cancer sometimes take it. So do I have to suspend Periop and how long? And obviously, there's no guidelines about ban mao. There's no blister beetles. So you would say that, hey, I'm sorry, I don't have that. But if you tell me more about this, maybe I can help you, right? So it doesn't hallucinate. And what it does is say, oh, it's actually a TCM. You don't even need to spell it out, right? So it's a TCM. Oh, okay. So because it's a TCM, I don't know the specifics, but these are the general approach to TCM. But if you need to know anything more specific, why not you ask the consultant? So that's what so really the model is able to do that, right? And by the way, if you look at down there that we said the Peach is licensed by our Health Services Authority for use in SGH. So we went one step further to make sure, because as I know, again, I completely agree with Dr. Beh just now, regulatory and all these are very important. So we make sure that it's registered by our Health Services Authority first before we use on our real patients. So we want to know what's the impact. So we have this, we have done this, we have done all the work. So other than being an academic interest, and we deploy, right? So we need to know, because all of these are expensive, by the way, even though we're not paying for it, government pay for it, it's societal, society is paying for it, right? So all of AI models, there are so many AI models out there. All of you, I'm sure, some of you will be doing your own AI models, but to deploy is very expensive. So we must make sure that whatever AI model that we do and deploy, there is a value to it. There is a ROI, right? It's not just an expense. So for us, we did this, and again, it's another article that we published in Nature Digital Med and PJ, to look at the clinical and economic impact of this. And it was the very first RCT in LLM for periop medicine that is done in the world, right? So hence the reason why it got published in NPJ Digital Med. And we supplemented with another evaluation, which was published in a smaller journal, Anesthesia. I'm sure most of you know, to show a more refined or more defined population. So we did that. We did RCT, 272 real-world clinical scenarios. And what did we find? We found that approximately we save about 6 minutes more for complex cases, right? That means, or rather how? Because our MOs, our doctors have at their fingertips AI capability that marries both international guidelines, whatever in the web, in the internet, with our local context. It's a very smart model, right? And it's able to, you don't need to think, you don't need to wait too long for the answer, right? So you type and the answer straight away came up, right? So approximately 6 minutes saved per patient. Huge. The more complex the patient is, the more minutes you save, obviously. And that translates to, remember I told you just now, we see a lot of patients at our clinic, and that to us, that translates to about 200,000 Singapore dollars per year for this one clinic only, right? So you can imagine if you were to expand this to multiple other clinics, it really is a very cost-effective model. And not just that, our users love it because it's easy to use. It's in your natural language model. I didn't have an example, but you can write just as just like how you would talk to a friend, and all those acronyms that our Gen Z doctors are using, no problems at all, right? One of my MOs asked let me know about something, LMK about LMK, let me know, right? LMK about what was it, anticoagulants or something like that. So just using the way the Gen Zs are texting and so they love it because it's so easy to use and very natural to them. And we launched that more than a year ago, actually, the 1st of December. So that's it's quite a while ago, more than a year ago. And people love it. And to date, it's actually the most used clinical chatbot in Singapore, which is Pet Chat, right? So the entire of Singapore. And I think we are very proud of it because it really has helped a lot of our doctors and our patients in that sense. So that's a picture. That's Yuhe. Yuhe is one of my consultants, who's also my PhD student. And she's the one who did most of the codings and really led the project. I mean, for me, I'm just the supervisor, but really because of her and her team's very good work, we're able to do this and deploy to the masses. So that's all. Just sharing a thank you, and that is my Periop medicine team in Singapore General. So thank to all of them actually that are able to do this very good work and deploy. So that's all. Thank you.
Thank you, Dr. Hairil, for painting such a compelling vision of the future, one that is both intelligent and deeply human-centered. So now we have come to the Q&A session. Actually, Dr. Hairil, I have a burning question. Since this AI and the GPT-4 is doing so much better than human job as a doctor, so you have evaluated the performance of AI on this patient's outcome. What about our training of doctors? You know that if doctors are so dependent on GPT-4, on AI, so have you seen any changes in the way they perform in exams? Or we are all coming from teaching hospitals, and what are the roles of doctors if AI is replacing most of our job? When they can do a better prediction, they can have a better consultation, just a few typings, and then we can get all the information. Yep.
So very good question. And in fact, I would say that there's so many things in your question. There's so many points in your question, right? One by one, right? So if I can take maybe your first point. Your first point is about complacency bias, basically, right? If you are using it, you basically de-skill after a while, right? Now, when I first started, I'm sure quite many on the call as well. When I first started, there's no ultrasound machine, right? We're using CVP without ultrasound, right? If you put in the CVP without ultrasound, there's no ultrasound guided block, right? We are using that nerve stimulator.
Yes.
It is unthinkable now to be doing a block or inserting a CVP without ultrasound. It's unthinkable. It was the same concern back then. People say, oh yeah, then we de-skill, and nobody will know how to find the CVP, nobody know how to do blind block. But does it matter? Does it matter? Our patients are safer, and our current generation of provider can do even better and more complicated blocks, even better for the patients, right? If you ask me about the blocks that I do 20 years ago versus what they can do now, it's amazing because of the advent of ultrasound. So it's the same thing with AI. We should not be scared that, hey, later, or, my doctors would not be able to do this and that. But we should embrace. And the question is, how do you embrace without making it, for lack of better word, our doctors, or rather, you lose the quality of care, right? So that's the question. How do you do that? Now, I feel that the first thing is that knowing is not that mindset that this will replace. So it's not a replacement. It is not. As you can see, what we've done with the model is not a replacement. You still need the doctor. The doctor look at it. The doctor use that information so that the patients are better. So most of my MOs now use the pitch actually as their study buddy. So rather than, if you're asking about exams, your second part of the question just now about exams, hey, they are actually using the pitch to answer exam questions and understand the reasoning, which is why AI models, in my opinion, is very important to have a reasoning model. So if you remember things that are, that some of the excerpts I showed you just now, most of my most of pitch's answer came up with explanation. It is not a black box. It's not a black box model. It actually tells you why I think this patient requires this, that, because the patient is high risk. Why is the patient high risk? Where they even give the source. If you realize just now, there's a citation, right? So where did I find this information if you want to read more? Or if you don't believe me, you can check in this reference. So I think it is not about whether AI will replace one. It is how you use it to mitigate the risk of complete automation bias. There will be a sort of automation bias, but how do you mitigate that so that our doctors actually become better, not worse? And it's the same thing with your ultrasound block, your CVP and whatever. Knowledge increase because we embrace.
Thank you, Dr. Hairil.
I hope I answered your question. Yeah.
Yes. All right. So my next question. So guys, if you have any question, you can just post it on the chat box, and we're going to ask the two speakers since we still have some time before the end of the session. So my next question is to Dr. Beh. Dr. Beh, as you mentioned before, one of the reasons we set up telemedicine, teleconsultation is because, for example, we are in PPUM, so the main concern in Klang Valley is traffic jam. But is this the implementation of telemedicine appropriate for, let's say, the whole Malaysia? Coming to, I see that there are speakers are working in other part of Malaysia. So what are the things that we need to be concerned about when we are trying to set up this teleconsultation for the patient? And also, what are the most effective strategies that to ensure the equitable access for elderly and low tech savvy patients when we are conducting these telecommunications? Do you think that what is your thought about it? Thank you.
Yeah, thank you for the questions. I also do enjoy Prof Hairil sessions. Then I was like asking my colleagues whether can we actually also use this AI to actually read our protocols, because we also do have this for our staff to actually look at the protocols, especially during some audits and MSQH audits. Nobody is going to read all these, like whatever protocols, whatever all these policies and all that. So I was like, oh, why not we also do this? Maybe I can ask Hairil as as an expert for this. Okay, so for the question, thank you, Nicholas. The first question you mentioned, let's say the patients are from other states, right? Whether they can actually been also recruited in PPUM teleconsultation. So the answer will be yes, actually. So we do have actually many patients travel from Pahang, Sabah, Sarawak, or other places to actually see me. So if I were to say that, I might as well you just being recruited in telemedicine, then you need to travel so far because sometimes they might need to travel, then the travel time, the fees and all that, the transportation fee, although then they might need to stay in the hotel. I have patient they stay in the hotel just to see me after that. So I was saying that might as well you need to do this, you just get recruited in telemedicine, then we can actually see you online. But again, it still go back to the same principle that it must be a patient that I've been familiar with, like have been seen with in my clinic for 2 years time, and then after that only they can be recruited. So for this, if let's say for preoperative wise, I think it's also quite a similar kind of principle. So if let's say they have been seen in preoperative clinic once, then I think the subsequent, if you were to order some investigation, whatnot, you want to review and all that, I think that's fine. We can still recruit them. Yeah. Then your next question, I hope you answer your question. And the next question related to what was
Elderly.
it again?
Like,
Oh
so
yeah, the
because we have these
equitability. Yeah.
elderly, more tech-savvy
Yes.
patients, so are they still a candidate like for this teleconsultation? Because I think these are the patients whom traveling can be a problem for them to get to the hospitals, to clinics. So do you have patients in
Yeah.
that category that you are still recruited into your teleconsultation?
Yes. I think that's a very famous question that been always asked. Then how about those elderly? They couldn't access to, like they don't even have smartphone or whatnot. So I think we have to be I know we need to be fair for all our patients and all that, but I think to a certain extent, sometimes some elderly patients, they don't have smartphone, they don't have even caregiver to actually guide them to use this. Then it will be a big challenge for them. They can't even download the apps for their usual, maybe Nokia phone and all that. So it will be very difficult for us to recruit them because one of the criteria for recruitment is they need to have at least a smartphone to download the apps, to access to the link and then to see the doctors through the apps. So that's why I think this group of patient, they might need to still be seen in physical. But of course, we have this option for other patients who actually need this and also they are able to and capable to use this service. So I would say that no choice to a certain point that we might not able to include this group of patient for this situation. So I do have another researcher actually talking to me that why not we set a hub. So set a hub in a like community area like some like so-called like tele hub kind of thing in some rural area. So where you have all these computers and whatnot, and then you have a system and all that. So when patients they do not have the smartphone, maybe they just travel to this hub, then they can access to teleconsultation, which is something that we can rip off, and maybe in the near future, it might be implementable. I think it's something that we can consider also. But of course, the cost-wise and all that also must make into a consideration. Yeah.
Yeah, I think that's a good idea. So, because I think in PPUM, I think primary care teleconsultation has been more established. In our anesthetic clinic, we have started for quite some time, but I think just a question like at what stage do you think your teleconsultation in primary care is at this level? Like because I think we have a lot of like barriers in terms of patient recruitment, also our MO's training, and also to get the things set up. So for example, like for our MO training, we are a teaching hospital. So every 6 months we have new MOs coming in. So how do you implement this education and training for your staff?
Yeah, it's a good question because implementation is always a challenge. So from one of the QIP, the quality improvement project that I've been doing, if we compare it with the Singapore, the other friends from Singapore from SingHealth, they were the clinic, they were really doing it very well. They, like I mentioned, they do recruit like more than about 1,000 plus patients per month. When compared to us, we're like 1,000 plus patients per year, which is a bit saddening the number. So that's why I think we try our best. So that's why we do this QIP, and also we sort of having some implementation studies where we actually do it from it's a mixed method study where we actually interview our patient, interview our doctors, interview our stakeholders to actually come up with what is actually their main problem, main barriers that we can actually. Then after that, now we are in the intervention phase. Like we're trying to create some intervention. But what I did previously was a very simple kind of therapy. Was we actually noted it was actually patients, like you mentioned. Actually, many of our patients did not know that we do have teleconsultation. That's one. So I think promotion is important. So we might need to put on, we put up some banners and all that in our clinic. So when patient they saw it, then they actually, oh, what is this? Then they actually, many of them they did not know. When you mentioned about it, they were like surprised, oh, you do have this, why I don't know. And I wanted to join. So maybe you can put up like some flyers and all that in your clinic. That's one. And of course, in surgical clinics, I think you need to work closely with surgeons as well for that because they are the one who need to refer and all that. So those are things. And then if let's say for the doctors wise, then like you mentioned 6 monthly, yeah, it was a headache. My headache because every 6 monthly I have to actually get their names and then submit to the teleconsultation team. I'm part of the team, so I have to submit to the person in charge and then to actually register them to go through this training. And after training, then they have to go through this kind of like system trainings again. So it's some work, but it's still doable. And I do have provided the workshop like physical workshop for them once in twice in a year for the to cater to teach the MO lah. Because sometimes some of the MO you might be surprised they're actually very scared. They because it's first time they're very scared. They don't know, oh, how am I going to see patients through Zoom and all that. So those are things that we need to empower them and also teach them like that some role play, that kind of thing to actually train them. And then for system wise, I think that's so far we have been trying our best to actually improve the system. So the main thing is the recruitment part is difficult because like you say, doctors don't want to recruit. This one are so many. So when initially when we started, we do 12 pages of the consent form. You can imagine 12 pages of the participant information sheet, inclusion criteria, consent form, everything. So it's like I don't even bother. If I were the MO last time, I wouldn't bother to actually recruit the patient because so many pages. Then we do have some, that's why we have some extra floaters. They are the teleconsultation ambassadors lah, basically. They are the housemanship. They finish their houseman and then they're floating in our department. So we get them to do this kind of work lah. So we get them to actually help in the teleconsultation recruitment. But again, the cost effective wise, whether this is existing manpower, they can see patient, whether they recruiting all this. So there's also need to make into consideration. So far, I've been doing all this. I think there's some improvement that I can see. So I hope it can be still sustainable in the future.
I think that's when AI actually helps a lot, right? If AI can do all this screening and then getting the patient, recruit the patient,
Yes.
I think that will actually help. Yeah, so
Yeah.
Dr. Hairil is also
If I can-
involved. Yeah, sure.
Nicholas, sorry,
Yes.
if I can add, right? I think the first thing is what is the North Star? Why are we doing this? I think must be getting back to the question of why. We shouldn't be doing something because we want to do it. We doing something because everybody do telemedicine, I need to do telemedicine. At the end of the day, need to understand why are we doing certain things. The North Star should be what is important to the patient, right? I think, I hope we can get back to that. Telemedicine is a very good platform, right? But before we go there, we need to understand our own patients from their patient experience point of view. What is important to the patient? So I give you an example. Somebody coming for lumps and bumps or some small excision with no medical history. This is the perfect patient, obviously, right? Because what is important to that patient? Hassle-free. Like what Dr. Beh was mentioning about parking, about movement, about waiting time, or all those things. Waiting in my home is much better than waiting in the clinic, obviously. But then if you were to ask what is important to a 70-year-old with a cancer, right, coming with multiple morbidity, I would say that particular person, what is important to that particular person is human touch. I want to see my doctor because this will calm me down. I want to be able to trust my doctor seeing in flesh. I do not want to be coming back again and again because investigations are missed. If I need to get investigation about blood investigation, or I just want to do it one time. I don't want to be cancelled on the day of surgery because something was missed during the consult. For example, a sign or whatnot that, because of the limitations of virtual consult, you are unable to find. And I think this is very important. It is not just about getting everybody, all your patients to be enrolled, right? So the North Star must be correct. We are doing it for the patients. Because of that, we need to understand and segment properly which patient are going to the, even for us, we have the same, as I mentioned just now, which patients go to our nurses to do teleconsult, which patient goes to the MO, which patient goes to the consultant. And for us to be able to segment this, we need to ask the patient. So we actually did studies and whatnot. What is important to that segment of patient? Without knowing that, it would be very, very difficult for you to just, blanket, everybody teleconsult. So I think we must be very, real about the patient population and what is important to the patient. I agree with Dr. Beh, saying that, okay, these are the ones that, sometimes may not, what was it just now? He was saying that will require a lot of care and whatnot. You shouldn't see. I think before we think about all the talks about, okay, we need more recruitment, we need this hardware, we need this training, things like that. First, understand your own patient population. What is important to them? For me, I give you an example. In Singapore, we don't really have that geographical issue. We don't, right? Singapore is so small. Traffic jam is not really a thing over here because cars are so expensive. People don't even own cars, right? They just take MRT and the MRT station is right under the hospital. So then the challenges are different. So our patient needs different things. So what is important to them might be different than what is important to your patient. So I really believe that when you want to design all this technology, AI, whatever, apps and whatnot, at the end of the day, what is important to that patient? I hope,
I think at the end of the day,
I
it's
know.
patient-centered care that is most important to all of us, right? Yeah, Dr. Beh, any?
Oh yeah, I was just thinking, yeah, you are right actually, Prof. Because we do have like I mentioned, the teleconsultation ambassadors, right? Sometimes they are very excited. They go and recruit certain patient who might not really keen, but then sort of like forcing the elderly who are actually some of the elderly they say, oh, I already retired. I'm happy to actually sit here to talk to the other patient rather than seeing the doctor through the screen. So in the end, if they say they recruit, we do recruit. I mean, this kind of patients still being recruited, and then up they will be defaulting the teleconsultation, wasted a slot. The doctor also wasted. How come this patient not arriving in the teleconsultation? So they also causing more problems to both healthcare providers and also the patient. So might as well
Yes.
I mean, it recruit proper and the patient who are really in needs of this service.
Yeah, at the end of the
Yeah.
day, it's actually patient-centered care. It's not about our KPI. Sometimes when we work, we are trying to achieve the numbers, the percentage of recruitment. So this is what happened when we are trying to achieve the numbers rather than seeing the patient itself, right? So yeah, Dr. Hairil is also involved in this value-based healthcare. So I know AI is a very expensive technology. So just a quick question of what have you seen as the key financial model for value proposition that convinced the hospital to invest? To set up this AI, how do we convince our hospital to put so much money to do such a thing?
Yeah. So as I mentioned just now, if you throughout my talk, if you notice, the last paper that I presented to you is the real world economic evaluation, and that should come. There are so many models out there; they are all expensive, and you need to show the ROI. So I think this is a key studies that have to be done, right? So you don't, again, back to the point that I made just now about, you don't just do things because you want to do it, right? Because it's there, because it's AI. Everybody do AI, then I have to do AI. No. If there's no value to it, if it's just troublesome to the patient, to your doctors, then what's the point? So when we did the economic evaluation, we really put about, we track how much time do you save our doctors. Doctors are overworked. I mean, I'm very sure doctors in Malaysia are even more overworked than doctors in Singapore. I know because my friends there, right? So knowing that, how can we save their time? How can we make them, help them rather than asking them to type more things, writing down more things, need to cut and paste and on whatnot. So I think that is the main value proposition, right? For AI, efficiency, better outcomes, right? Better training. And how do you then convert that to dollars and cents? And I think because, at the end of the day, let's face it, when you want to go up to the executives asking for funding, it is about dollars and cents. There are so many things in the hospital, in the healthcare system that we need to fund. Why do I need to fund your project? So it is up to you to be able to calculate that ROI in dollars and cents. And I think that's a reality, but it can be done. There's framework for it. You can see some of my papers use that framework, right, to come up with the dollars and cents. Yeah, definitely it's important. Don't just do something because everybody else is doing it.
Okay, thank you, Hairil. So is there any questions from the audience? So if not, I would like to promote this first Malaysian Perioperative Medicine Symposium 2026. So if you want to engage more with Dr. Hairil, he will be there. So it will be on the 28th and 29th of March 2026 in Bangsa South. So do sign up. I think there's a QR code later. And we have reached the end of our time. Before that, do we have anything from Dr. Hairil or Dr. Beh before we conclude this session?
No, I just thank you for the invite, and as mentioned, it was I enjoyed the base session and Nicholas, and I guess I'll be back in
We'll see you
KL in a
soon,
couple of months'
right?
time. Yeah.
And Dr. Beh?
Yeah, I think nothing much from me, and thanks for the invitation. Yeah.
Thank you for joining us for this very informative session. So, now we are clearer with how to set up with our teleconsultation and definitely how AI works for a betterment of our patients' care, definitely. So I want to extend a huge thank you to our brilliant speakers, Dr. Beh, Dr. Hairil, and for sharing your expertise, practical insights, and also visionary ideas. So for the audience, do check out on our promotion, the poster, if you would like to sign up for the first Perioperative Medicine Conference in Bangsa South this coming March. And thank you for your attendance today. And I think there's a survey form available for you to give us feedback for better to improve on our webinar. I think there will be a pause of webinar until coming June, so do stay tuned for more updates. So I think that will be the end of our session, and thank you for joining us this Saturday morning. Have a great weekend. Thank
Thank
you.
you. Thanks.
Thank
Bye.
you. Thank you so much. Bye-bye.
Bye.